vitiligo. I think it looks cool, but
I think it's beautiful.
Yeah. But some people are self-conscious about it, and I think that's reasonable. If you want, some support, definitely, we can definitely help you find it.
If you get bullied by someone for your vitiligo, just leave a comment with their name and their telephone number, and I will call them and yell at them.
She'll beat you up with her broken wrist.
Yeah. See these bruises, want to know how I got them.
Real skin, real science, real confidence. With Dr. Zain Hussein. Welcome to
Skin Side
Out.
Welcome to Skin Side Out. I'm your host, Dr. Zain, with Heather and Courtney. So today we are uncovering vitiligo from the inside and out. So let's get right into it. What is vitiligo?
So with vitiligo, you are losing your melanocytes, and your melanocytes are your skin cells that produce melanin or give your skin its color. And you can either have a decrease in your melanocytes or you can have complete absence of your melanocytes. And so this very classically, I think we have a really good photo, but it's these very well demarcated white areas. It's kind of like a milky white appearance to your skin. So it's kind of common. We see it pretty frequently, but thankfully there are some really good treatments.
All right, so let's talk about some stats. So what are we seeing in terms of the population? How many people are affecting?
So it affects about 0.5 to 2% of people, which doesn't seem like a grand scheme, a lot of people. I think also we see it really occurring in any age group, any ethnicity. It's a very non-discriminatory, disease, I would say. Usually we'll see it before 30, but sometimes we'll see people in their later age as well getting small spots. And I think more so, when people think of vitiligo, they think of more widespread area, but I think more commonly we see just smaller patches here or there. It's not normally as widespread as like that photo showed.
Yeah, and it can affect all skin types. So even lighter skin patients, it's harder to sometimes see some of the depigmentation. And it's definitely a lot more obvious in, skin of color where there's a lot more contrast. But, we see a whole variety of, grades of this depigmentation, hypopigmentation.
I think we see it a lot more in the clinic in not only like darker skin types, but also in females, even though it's non-discriminatory. I think, number one, like you said, with darker skin types, it's more noticeable, but also like with the females, I feel like they're just more like, they have more of that like cosmetic eye.
More observant. We can say that, more observant.
So I feel like they tend to come in sooner when they notice things. Like
that. And also like it can affect cosmetically sensitive areas, right? And, unfortunately, vitiligo is one of those conditions that's often stigmatized. It's been, stigmatized for years, like millennia, to be honest, like something's wrong with there's nothing wrong with you. It is totally normal. It's just a condition that, affects the pigmentation.
Yeah, I think, there was that supermodel, Winnie Harlow, who I think really brought attention to vitiligo and really destigmatized it. And, she's obviously beautiful woman. And I think she's kind of set the pace of, diversity is important and that it doesn't make you any less beautiful.
Yeah.
So there are different clinical subtypes of vitiligo. So we commonly see non-segmental vitiligo, these patches that are often, found anywhere on the body, and they're, typically bilateral and symmetrical, but does not have to be. So that's something that we do see quite frequently. There's also segmental vitiligo. So Heather, do you want to go into that?
Yeah, so segmental vitiligo is where it's only affecting a segment of your body. So like the left half of your chest or your trunk. And this often is related to dermatomes, which is a term that we use that represents skin areas that a nerve follows. And so there's this hypothesis that there's some sort of neurogenic contribution to vitiligo, especially with segmental vitiligo.
And then, of course, there are like mixed types and others that are unclassified, but there are also like descriptors like, you got your hands involved, so some acral vitiligo, periorificial vitiligo around your eyes, around your mouth. So there are different clinical subtypes that we can categorize these patients. So what causes vitiligo?
It could be a lot of different things. There's a long list. So vitiligo is commonly related to your immune system. So sometimes your immune system can cause that destruction of the melanocytes. There are some associations with different autoimmune conditions like thyroid disease, diabetes, some types of hair loss like alopecia areata, but you could have none of these and still have vitiligo. We also see a little bit of a genetic predisposition with that. So if you have a family history of vitiligo, you're more likely to get it, but not a guarantee. Stress plays a really big role in vitiligo. We do see that very commonly. And I think that also has to do with the effect on the immune system. I know I kind of mentioned the neurogenic hypothesis. So especially with like the segmental vitiligo, there might be some sort of contribution with neural mediators, and then triggering factors. So like the stress, illness, which I think is also a very stressful event. Trauma, we call that the Koebner phenomenon. So like if you scratch yourself and then you get vitiligo there. Sunburns, and then also chemical exposures. And we mostly commonly see that with phenol compounds.
Yeah. So obviously vitiligo is not something that we know the exact cause of, but we do have some hunches that it has a lot to do with autoimmunity, and other environmental factors can play a role. So these patients typically come to us in the office, oftentimes with usually limited areas of depigmentation or hypopigmentation. So how do we differentiate between other causes of hypo or depigmentation? So there are conditions that can look very similar, such as a form of eczema called pityriasis alba. We have other conditions such as tinea versicolor that can lead to hypopigmentation, or basically any remnants of old inflammation can lead to hypopigmentation. So there are tools that we can use. Obviously, when they're like milk white, very well demarcated patches, it's a pretty easy clinical diagnosis. But sometimes when it's subtle, I like using my Woods lamp, where we use UV black light to really look at and see if it's true depigmentation or it's just hypopigmentation. That can help us.
Yeah, a lot of times with the Woods lamp, what we're looking for is if that milky white is being accentuated or getting even brighter and more pronounced with the Woods lamp. Pityriasis alba, I think, is a really good one because it's very classic, like on the face, but you get this depigmentation and it's not a full loss of pigment. So you have more of like this faint hue of melanin, but when you put a Woods lamp on it, it's not going to be accentuated.
I usually see it in the context of dry skin. So oftentimes these patients are moisturizing.
Yeah, I was going to say, I feel like it's not as well demarcated as true vitiligo is.
Yeah. So let's talk about the primary features. So we talk about the milky white depigmentation. It's always flat. So it is not raised. So that's an important point because there are sometimes, patients who get these confetti-like lesions. They think it's vitiligo, but they're actually a type of seborrheic keratosis, and it just looks lighter than their skin, but it has elevation. When we look under dermoscopy, we can see features of these seborrheic keratoses. So I think that's really important. Common locations. Where do we see vitiligo?
Face, hands, it could be anywhere, but I do tend to see them like on the wrists, on the neck. The nice thing is the face typically responds pretty quickly. I think the sooner that you treat it, the better improvement you'll see. The hands are really hard to treat, and the feet.
Yeah, I agree. And sometimes it's limited to the genitals. So we do see that especially men, I see that quite often.
Yeah.
Where either the glands or the shaft, is affected with vitiligo.
You can get it too in the hair, and your hair can turn white in that area. So that's called Leukotrichia. I think we have a photo of that. So you actually have a patch of the vitiligo within your skin, and then because it's a loss of melanin, your hair follicles there no longer have melanin either.
This is not to be confused with gray hair, which is what Dr. Hussein has.
Hey,
So
I like it.
stop telling people you have vitiligo.
Yeah, it's more of like a striking,
Like a streak.
yeah. So that's somebody's eyebrow, and you can see the biggest
So
difference.
do you guys watch X-Men when you were younger?
Yeah.
Rogue?
Yeah.
Oh, that streak.
Yeah,
I think she had vitiligo.
yeah.
She was a mutant, so she had a lot of stuff going on.
She was awesome.
Yeah.
So how does the course look like for vitiligo?
It's very unpredictable. It can, can just have one little spot and we treat it and it goes away and then you don't really notice anything else. But you could have, a pretty widespread case. So it kind of depends on your body and probably your immune system.
Yeah. Sometimes when you catch it in the early stages, you can see the actual inflammation. Like the skin's actually looks red. It kind of spreads, and then you start noticing the depigmentation. So during that inflammatory period, it is actually really responsive to treatment because we can reduce that inflammation and prevent that pigment loss. But it's really rare to actually catch it during that phase because patients usually come after the fact.
Yeah. Yeah. There's a type of vitiligo called Trichrome vitiligo, which I think we have a picture of that as well. And that is where you can see the different stages within the vitiligo. So like here, it's kind of blurry, but you can see like in the middle, you have full depigmentation of the melanocytes. But then kind of towards the outer edges, you can see that either it's starting to progress or they're responding to treatment. And it's hard to know without knowing their history. But you get the milky white, and then you have a light brown and a dark brown all within the vitiligo patch.
Yeah. And then these types of patients have some considerations for their health, correct? So since they don't have pigment in those areas, do they have any protection from the sun?
No.
So they're more prone to sunburn. So they have to be really careful. And then also, because they're more prone to sunburns, they can get skin cancer in those areas. So that's something that we really want to stress with our vitiligo patients for sun protection. And then let's not discount the psychological effects of this condition. We had mentioned that this has been stigmatized for millennia. And, sometimes these patients are outcasts in society. And it's really sad to, kind of see how these patients have been treated, in the past in certain cultures. And some people are thought it's an ugly feature. They have difficulty, finding partners. And it can be a really traumatizing, condition to live with. All right. So diagnosis. So oftentimes this is a clinical diagnosis. We're assessing the patient, sometimes using our Woods lamp, but it tends to be pretty obvious in many cases. What other labs can we look at when we have a vitiligo diagnosis?
I think it might be worth checking for any sort of autoimmune conditions, any sort of screening. Thyroid is a really common one, especially if you have vitiligo in your underarms. It's not a guarantee, but there's a higher association with thyroid conditions.
And, vitiligo was a condition that was very difficult to treat for many years, but now there are a lot of different options. So let's kind of go through the different treatment options for vitiligo. So let's start off with topical therapy. So what topical therapies do we often use for our vitiligo patients?
So first line that, we'll use, especially if it's more localized, a smaller surface area, would be something like a topical steroid. And that's really just going to reduce that inflammation. You might also have your non-steroidals, so things like tacrolimus, pimecrolimus they'll use. And that I think we have found to be pretty helpful too, especially in those more localized areas. Of course, you don't want to use a steroid over time. It's going to thin the skin. So I think switching over to something like the non-steroidals is important. Phototherapy, which we don't use as much anymore. I know we don't use that in our office. So that's going to be that narrowband UVB. It again carries the risk of skin cancer. So it seems a little counterintuitive, I think, for a vitiligo patient.
Yeah, I agree. I totally agree. We did narrowband UVB at my previous practice, and it works. It
does
really works.
And the vitiligo patients that use it will come back. Like they get addicted to it.
Especially with one of the newer topicals that we use, Opzelura, which is a topical JAK inhibitor. And this one, I think, does a phenomenal job. It takes time. It takes probably like 6 months before you really see anything, but it works so, so well. And it works even better when you combine it with phototherapy, unfortunately. But like you had mentioned, the skin is so much more susceptible to sunburns and any sort of UV damage. So the UV is going to increase that risk of skin cancer in those areas. But I've seen really, really good success with it.
Yeah, I mean, we used to do a ton of narrowband UVB in residency, and then PUVA also.
Yeah,
and
PUVA's scary.
It's very scary. I mean, we see so many skin cancers from that.
Yeah.
But it does work, and sometimes like I don't advocate for this at all, but some patients, especially with costs, go to tanning beds, or just go outside without any sun protection to get some of that repigmentation. So it is a treatment option, not really my favorite. For smaller areas, though, I think the Excimer laser can be very helpful. It's a specific wavelength of light in the UV spectrum that can really help to, induce some repigmentation, but for localized areas.
For oral treatments, there's nothing that's FDA approved for vitiligo right now, hopefully down the pipeline. But you could potentially do a short course of a corticosteroid. I don't love that for vitiligo because I don't think it's, I don't know what your opinion is on it, but I don't think it's typically enough to get that response going, and you can't keep them on it long term. But hopefully, I mean, we're hoping to see really good success with JAK inhibitors, which are, like I said, Opzelura is a topical JAK that does a really nice job. So we're hoping some orals get approved soon.
Okay. And I know that they've been used off-label in a lot of different places, and they have seen success with it.
Yeah.
But we're still waiting for that FDA approval. So let's talk about some surgical options. I love procedures, so there are some really cool techniques out there. So there are melanocyte, keratinocyte transplantation that you can perform, punch grafting, where you take skin from other parts of the body that have normal pigmentation and actually, graft them into places where there's depigmentation, suction blister grafting. So basically, we're trying to take cells, the melanocytes, in areas that are producing normal pigment into areas that are depigmented. But my thoughts are, I mean, that can work, but what if you start developing, antibodies and it just kind of depigments that? So I haven't done it, but it's interesting.
Well, and I would think also if it's kind of trauma induced, like I remember a couple of years back seeing some reports about microneedling with lattice, because the lattice is supposed to bring back that pigment actually. When you're microneedling, of course, you're opening those channels, and then you apply the lattice to that area. And it was interesting. I did treat a guy at one of my previous practices who had vitiligo on the face, and we did try that technique, and it did, I think, brought a little bit of pigment back, but there was still that concern of if we're traumatizing the rest of the skin. We only treated that area because I didn't want him to develop any new vitiligo spots. So it's kind of a catch-22, I think.
Yeah, it's funny. I actually was talking about that with a patient today who has had vitiligo in just discrete areas, but really hasn't budged with topical steroids, calcineurin inhibitors, tried Opzelura, so nothing's really worked. So I think we may go down the path of, microneedling with lattice and seeing if it helps.
Yeah, I had good results with him for sure. And I think, like I said, it's definitely, there have, been nice studies on it, but I think unfortunately it's not consistent with the results. So
yeah. I mean, sometimes, you just have to try and see if you respond. So, with patients who have extensive vitiligo, like large body surface areas, we're talking about like for 50% of the body, there is a different way that you can actually not treat it, but actually kind of make the patient feel better about their, appearance psychologically. So You can actually depigment your skin. So monobenzone has been used for a long time. It's like a chemical bleaching agent. And it does work, but it really does require some, psychological testing prior, because it can be such a jarring experience after being depigmented. And once you do it, you can't reverse it. So it is something that, we can offer, but it's usually very, very rare.
Is that what MJ did?
I don't know. Do you bleach just the normal skin, and then like what if your vitiligo patches repigment, or do you just bleach everywhere?
You bleach everywhere.
Oh.
Yeah, it's interesting.
Yeah.
I've never done it with any patients, and I don't have experience with it, but I know that there is an extensive pre-op kind of questionnaire and like testing that you need to do and make sure that they're mentally prepared to deal with the consequences, because it is a big change.
Yeah.
What else can we do for vitiligo patients?
Like we mentioned, sun protection is going to be a big one. You definitely don't want to risk sunburns in those areas. If you're interested in kind of camouflaging those areas, there are techniques that you can use. Most of them are just temporary, but we can definitely.
Dermablend is a really good.
Yeah.
One of my attendings swore by Dermablend for her vitiligo patients, and it works.
Yeah. And I think like we already mentioned, but something that we don't want to just slide by is the psychological support that people may need with the vitiligo. I think it looks cool, but
I think it's beautiful.
Yeah. But some people are self-conscious about it, and I think that's reasonable. If you want, some support, we can definitely help you find it. Yeah.
If you get bullied by someone for your vitiligo, just leave a comment with their name and their telephone number, and I will call them and yell at them.
She'll beat you up with her broken wrist.
See these bruises, want to know how I got them.
So how did these patients fare? What's their prognosis like?
Good. Yeah, I think it's pretty good. I think it's worth, letting them know that it's going to take time and just preparing them to be a little patient in the beginning, but people seem to do pretty well. Yeah.
And I think it's also a function of how long they've had it. So the longer they've had it, the harder it is to get repigmentation.
Yeah.
Also how extensive it is. Certain locations like the hands, like we talked about, are very, very stubborn. Yeah. So there's a lot of different factors in play. So it's kind of variable.
Yeah.
All right. I'm going to ask you guys, because you're the professionals. I'm just the esthetician. All right. Is vitiligo contagious?
No. Not infectious.
Is it hereditary?
Can be.
Yes.
There can be a genetic predisposition.
Is a good diet going to cure your vitiligo?
No, but I think a balanced diet is going to help with just keeping your skin healthy.
Life in general.
Yeah.
Does stress cause vitiligo?
I think it could be a trigger. It's multifactorial, but I do think that stress can be one of those triggers to start it.
Is vitiligo associated with any kind of cancer?
It's not cancerous, but hopefully we've beat it into your brains that you are at a high risk for skin cancer. So you just have to be cautious.
Well, interestingly, sometimes we do see halo nevi, which are these moles that have depigmentation around them. And sometimes they are representative of a regressing melanoma. So anything that's new and changing, that is something that you want to bring up with your dermatologist, because that could be a subtle clue, as to an early melanoma that's evolving.
If someone is albino, is that a form of?
No. It's a genetic disorder, where there's actually a mutation in the pathway to produce melanin. Yeah.
Okay, so they're kind of like cousins, like second cousins. They share a great-great-grandfather.
Yes.
Well, one is genetic, and that's like in utero, right?
Yeah.
And then there's one that is
autoimmune on its own.
Yeah.
Okay, like an adopted
I think
cousin.
Yeah, and maybe albinism is affecting like the pathway earlier on than vitiligo.
More studies need to be done.
No.
From Courtney. Jot that down. And then last question, is there a permanent cure for vitiligo?
No.
Unfortunately.
But there are good treatments.
All right, so I think this wraps up our discussion on vitiligo. I think it is a condition that many people are aware of but don't really know too much about. And it's good to have knowledge because it can destigmatize this condition. It also allows for patients to have hope because there are newer treatments coming out. There are different treatment options that we have been able to use successfully. So there is always hope. And like Heather had mentioned, it's really important to stress sun protection because you have no protection in those depigmented areas. So those are 3 big things that I want to definitely emphasize. Any other last minute tips, information?
Have you guys heard of the micropigmentation for the vitiligo? People will do that sometimes.
Like tattooing?
Yeah, so sometimes people will do pigment. I know I've seen it for even just people doing like makeup on their face, which I don't recommend. I think it's probably not good to, I don't know. I don't recommend it. But for vitiligo, I've seen some people do it where they're basically filling in that lack of pigment. But again, you do have to worry about kind of the trauma of once you're creating more trauma, you're again kind of chasing the end result. So I don't know. I think the dermablend is definitely a better option, even though it is temporary.
Also, vitiligo is not always static, right? It can be dynamic. And what if you get your tattoo and it starts evolving beyond the border? So,
just get like a cool tattoo. Don't get like pigment tattoo. Just get like a cool, like my tattoos, get cool tattoos and then cover it up. If you want.
Or get a cast instead. They'll cover it up.
Yeah, get a cast.
Just cover it up with a cast.
Just go snowboarding and almost break both arms, and you'll not be able to tell. The bruising will definitely take over the vitiligo.
Or just embrace it.
Yeah. Yeah, I think at the end of the day, our message is just embrace it.
Well, I think this wraps up our episode. Until next time, skin side out.
Thanks for listening. This episode of Skin Side Out is complete. If you enjoyed today's episode, don't forget to subscribe, rate, and leave a review wherever you listen to your podcasts. For more tips, updates, and behind-the-scenes content, be sure to see what fun we're up to on TikTok. Follow us on Instagram and Facebook at Nor Dermatology and Aesthetics. Check us out online at norderm.com. Discover why our patients give us 5 stars on Google. Call us today at 919-617-0717.